Good evening. My name is Dr. Frank Jones, and I'm president of the Atlanta Medical Association. And this is the second installment of our new series called AskABlackDoctor. One of the things that we want to be able to do is to allow our community, our patients, and also healthcare providers to be able to call in or write in or just view some of the ideas and some of the conversations around our health issues with Black physicians. And so that's a new series that we have started. The first installment, we talked to Dr. Miller Collier. He's a family physician, and we talked about some of the issues as far as patients in the community is concerned for coronavirus. This time, we are pleased to have Dr. Joyce Drayton, who is an infectious disease specialist, and we're going to have her introduce herself a little bit more. As I mentioned, my name is Dr. Frank Jones. I am a general surgeon by training, and I'm sure you're asking what's a general surgeon doing talking about coronavirus. But my role here today is as president of the Atlanta Medical Association. Just a little bit about myself. I am adjunct faculty at Moore School of Medicine in the Department of Surgery. I'm also adjunct faculty at Philadelphia College of Osteopathic Medicine, the Georgia campus. But again, my role here today is as the president of the Atlanta Medical Association. One of the things that has disturbed me is on all the coverage that we've seen on television, whether or not you watch MSNBC or CNN, I have not seen not one Black physician, not one Black nurse, not one Black social worker talking about it. And we know that we are qualified to talk about it, and we know that our community wants to hear from us because they have a lot of distrust from some of the other individuals. So I'm glad that you're here. And why don't you tell us a little bit about yourself, a little bit about your training?
Again, my name is Dr. Joyce Drayton. I'm a graduate of Howard University, both undergrad and medical school. Completed residency at Henry Ford Hospital in Detroit, and my infectious disease fellowship at University of Miami at Jackson in Miami.
Okay.
Left there and joined the faculty of Morehouse School of Medicine for 10 years and am in private practice now and medical director of infection control at some area hospitals.
Okay. And so we're just going to have a conversation. We're going to keep it real. And next time we'll have questions that can come in from the audience, and we'll be able to answer them live. But for right now, we're just going to have a conversation. So tell us a little bit about coronavirus and exactly what it is.
Well, coronavirus is a new virus. It's an emerging infection. That's how we refer to it. And it was noticed in the final quarter of 2019. Is believed to come out of Wuhan, China. And there's not a whole lot we know about it because it is new, but we do know it's in the coronavirus family. And that's the virus that's very closely related to SARS. Some of the physicians will remember that, or MERS-CoV. These are all in the coronavirus family. And they typically cause very severe lung disease.
And I've heard or read that it was related to a bat, that originated in a bat. Is there any evidence of that?
Well, that's the theory. That's where the Chinese have been tracing it to what we call a wet market. And you may, if you've traveled in Asia in particular, you'll know that wet markets will have merchants who come with prepared food. Some will come with animals that are already slaughtered, and then others will come with live animals that are slaughtered on site. And so there's a lot of, mixing and, of both prepared food to the live animal that you'd have cooked on site, and it's been traced to one of those. Because the other coronaviruses are believed to have come from bats, MERS-CoV from a bat to a dromedary camel to humans, and SARS from a bat to a civet, which is a rodent, to humans. All these coronaviruses believed to have come from that source as well.
Okay. And because we are healthcare personnel and we work directly with you're really in the trenches taking care of these patients every day, are we at any increased risk?
Well, certainly healthcare providers are one of the high-risk groups. So CDC has criteria by which we assess a person for risk. And we refer to them as a PUI, a person under investigation until we get the test back. And those people will be anyone who comes in with a fever and a cough or shortness of breath. High-risk demographics would be a person who's traveled abroad or had contact with a traveler. Or healthcare workers who've been in contact in hospitals where they may have been an infected patient. So we're very, very conscious of what is your profession, in what setting in which you work,
Now, I was sitting around the other day talking with some of my colleagues, and some of them are emergency medicine physicians.
Okay.
And so I just asked the question, what are you doing at your hospital? If someone comes in and they are symptomatic or if they have a fever, what do you do? unfortunately, even as emergency room physicians, they didn't have the answer to that question. I mean, what do we tell our physicians and nurses and nurse practitioners and PAs?
Okay. Well, certainly the emergency room is the front line, and my husband happens to be an emergency room physician. So, but immediately in triage, there's certain questions that are asked, and so does the person have a fever, a cough? Have they traveled? And we look for those high risk, exposures. And then immediately that patient should be put in a separate room, and a mask should be applied to the patient. Okay, so that's one thing that we do immediately, and then the physician will have to come and assess, if there's some other cause for that. But we're really, very, very vigilant about that at this point.
And let's back it up a step. If someone is at home and they're symptomatic and they have some concern, should they go to the emergency room, or what exactly should they do?
Well, they should make a phone call before they show up anywhere. So if they decide to go to their physician's office, they need to make a phone call so that the office can prepare and anticipate that they will come. They may give them instruction depending upon the history. If they say they have fever, cough, and I'm feeling short of breath, and they have no history of asthma, they may be instructed to go to the emergency room. And then we would ask that office or that provider to call the emergency room to which that patient is going to give them a heads up so they can prepare for that patient's arrival.
And what are some of the signs and symptoms of coronavirus?
Again, some cases have been as simple as fever and cough and maybe a stuffy nose, but that would tend to occur in younger patients who are very healthy. The more severe cases in any epidemic or pandemic are the ones we see first because they come into the healthcare system. And so those patients will develop fever, cough, shortness of breath. They've done a few series already, and they find that around day 8 or 9 is when they have a very quickly blossoming pneumonia. They will go into complete, they can develop a very severe pneumonia requiring support from a ventilator. And so it can be from a relatively mild disease but to a very severe disease, particularly if you're older and if you have certain chronic illnesses.
What is the temperature at which we should be concerned?
Well, any fever is of concern if you have the whole constellation of symptoms. So it's not simply a fever, but if you're having a very achy flu-like illness, and a fever of 100.8 could be significant.
Okay. So just asking the question a different way, some of the things you've already pointed out, but who should get a test?
Okay, at this point, that should probably be determined by the healthcare provider, whoever you see, if you're coming to a clinic or an emergency room. One of the reasons that we don't just screen everybody is that no test is 100% sensitive or 100% specific. So the more people we give a test who have no symptoms, the greater the number of false positive tests. And that causes a big problem because then we start, if you have a false positive test, we're doing all kinds of investigation of your contacts unnecessarily. So we do want to test people who do have symptoms, not people who are asymptomatic.
And where are we with testing? I mean, we were promised that we're going to have 5 million tests by last weekend, and that hasn't happened. We still haven't really ramped up. Where are we with testing?
Well, we might have 5 million tests, but they're not readily available in your physician's office.
Okay.
So you're talking about a brand new infection, and it takes time to standardize the test, to find the antigens that we use to make it, reasonably, able to detect the virus. Initially, the only place testing was the CDC. Relatively quickly, every health department was able to offset some of the burden that was on the CDC. So we have testing now within this state at the Department of Health, but they quickly got overwhelmed. And now we have testing at the commercial labs, Quest and LabCorp. Quest tends to do tests on hospitalized patients. Outpatients tests tend to be sent to LabCorp. But it is still a test that's not done all over the country in every Quest lab. So there's a little bit of a delay, but we've been able to put through a good number of tests and be able to tell people. And it's very important to be able to tell a person you don't have it. And so we can start looking in other directions and treating them differently.
So as a clinician, if I'm really concerned about one of my patients and I say my patient needs to get tested, in Georgia right now, in Atlanta, how easy is it to get a test?
Well, you can test in the office. Quest has a code, and it's COVID-19 testing, and there's a code for that. You collect it the same way you would a rapid influenza screen or a multiplex screen with a nasopharyngeal swab. You go back and per patient's nose, twirl it around, and you put it in a particular kind of media. So you can call Quest to do that in the office, and there are physicians who's testing in the office already.
Now, what happens once the test is done? Does it have to be sent to another location, or?
No, you send it to Quest, and then Quest gets it to the lab, to the location in which they do that testing. And they've been wonderful about calling you before they even send it out. They don't count on an email or a fax. They will call the physician to let you know immediately before it's even in the system, so that you can address it with the patient.
So is that going to present a roadblock? So even if we had 10 million tests, is there still another step that we have to go through that is not quite ready for the ramp up in testing?
I'm not too sure about the question. I do know that before we had the test in the commercial, Quest and LabCorp, it did take a call or an email to the Department of Health. You had to be sent back a special number to put on the specimen, and then you sent the package out with a special box. But we don't have to do that anymore. You can simply call Quest, get the collection, device, and send it off.
Kind of walk us through, once you get a call saying that we're concerned about this patient, we want you to come see them, what happens after that from your perspective?
Okay, I work in the hospital setting, so typically I'll get a call maybe from the emergency room, and the first thing we do is we want to rule out other common infections. So the quick things we can do, the tests for which we have a rapid test, are influenza A and B, and that we can do in a matter of minutes. Strep screens, quick. But once that's negative, then the emergency room physician is going to do what we call a multiplex or upper respiratory PCR. And that test will take an hour to a few hours, and it tests for very, very common viruses, rhinovirus, adenovirus, parainfluenza, and we, want to rule that out. But if the patient has the typical symptoms, and there are really only a few, fever, cough, and shortness of breath, but they're 69, 79, they have diabetes, they've known to be on dialysis or have other illnesses, and the x-ray. If they have any kind of changes on x-ray, then chances are we're going to, err on the side of being overcautious and likely admit that patient for, COVID testing.
Okay. Now, what about that patient who you're very concerned about? You test them for the flu. They test positive for the flu, but could they also have coronavirus at the same time? What are the chances of that?
Well, they could have co-infection. I can tell you in my personal experience, which, because it's a new disease, is fairly limited, there have been a couple of people who have tested for flu, and they've had the flu and gotten better. I've had a patient who's tested for respiratory syncytial virus, and that's what the patient had. Another had a different kind of coronavirus, because on our panel there are 4 coronaviruses that cause common cold symptoms that are different from this virus we're dealing with now, the COVID-19 virus, and there's a patient who had that, and none of those have had both infections. But I can't say it's impossible, but...
From a novice infectious disease person, from my general surgery standpoint, what I've been hearing is there's such a big relief if you test them and they have the flu. But are we missing some patients that may be having both of them?
Well, so far we've screened most of the patients who get admitted to the hospital. They've ended up having both that multiplex test that I've taught you about and a COVID test. Now, there are patients who present and they're not that sick, and the emergency room physician can make a decision to screen them and send them home with instructions about how to quarantine at home if their home situation allows for that. So every patient who has it is not necessarily a candidate for admission.
So let's kind of talk about that part of it, and this is also for our patients. I know this is kind of geared towards our healthcare professionals, but definitely for our patients as well. Who should self-quarantine? And tell us a little bit, what is self-quarantine and who should do that, and And a lot of new terms have come into our vernacular now. Social distancing and what that's all about.
Okay. Well, there are, I would say, kind of two groups of people who might want to self-quarantine. There are those who have been exposed but don't have the disease. And then there are those who are ill and diagnosed with the disease. So, for example, if you've come off of a cruise or you've come from a place in which it's very, very endemic and there's active infection, you will self-quarantine for at least 14 days. The health department will likely screen you and test you, and they'll give you guidance on that. And those are people who may not have symptoms. They won't have symptoms, but they'll self-quarantine. But others are patients who actually have been diagnosed, and they may not be sick enough to be in the hospital, but they then would have to quarantine at home as well. And they'll be screened before they're, the health department says it's safe for you to go back to work, for example.
Is there any evidence that social distancing works? I mean, we know what happened in China where they really shut down the city or the country.
Well, any disease is caused or transmitted through person-to-person spread, certainly. It's just closing the school, for example. No one's touching the doorknobs and wiping their nose and, blowing their nose and, the ways in which we don't think about it, but we have to live and may catch, a virus. So social distancing does work. It does decrease, transmission.
Let's talk about some of the other rumors that are out there. One that us as black folks, we can't get coronavirus. Is that true?
No, that's not true. We can get coronavirus. I think that comes from the fact that there are disproportionately, seems to be fewer cases in Saharan, sub-Saharan Africa. And there seem to be fewer cases in India, for example. Now, part of that can be that they may not have as many, healthcare facilities with the ability to test, and maybe people are coming in with symptoms and not being diagnosed. But there's also a theory that, of course, you've heard that this is probably going to burn out and we'll have far fewer cases when it gets warm. So you're talking about countries that are equatorial, it's summer there, and on the other side of the equator, and the heat, can't live in the heat, and people are outdoors and such. But now, yes, we can get it.
Putting on your infectious disease hat, but also putting on your common sense hat, would you go on a cruise right now?
I would not go on a cruise right now.
What about flying in an airplane?
I would avoid flying in an airplane. And I say that because I have a son in California who I want to come home. He's going to have to fly in an airplane. But airlines are taking extra precautions. I know everyone knows, I'm in this plane and there's this recirculated air. But the airlines, I know Delta is spraying, antivirologics, antivirus, and antiseptics in the air and doing a circulation of the air between flights. So they're making an effort to kind of clean the air.
I was mentioning on our segment earlier, my son just went to LA on a spring break trip. I mean, I tried to give him every reason in the world why he shouldn't go.
And I'm trying to get mine to come back from LA.
So make sure you're practicing social distancing while you're there. But what about eating in a restaurant?
Well, it depends on, CDC has really wonderful recommendations based upon how many cases are in your city. And so there's minimal things that you can do that are personal things, within the social distancing. Kind of moderate things would be not having a gathering of more than 250 people, for example. And so there are quite a few church services that have been canceled today. And then the very more severe precautions in a city like Seattle, where there have been many cases, New Rochelle, New York, San Antonio, where we have the mayor declaring an emergency. Many restaurants aren't even serving. So even the small gatherings you want to avoid those as well.
What about those patients that are coming to the hospital for non-emergent things? They come to the hospital for a regular clinic visit or elective surgery or an elective procedure.
One of the recommendations is that any elective procedures or elective clinic visits, just don't do any elective visits that aren't, in which you don't have a problem or you need a refill. Try to refill without seeing the patient if they're a reliable patient and you have a long-standing history with them. I, in fact, have canceled my clinic for the next few weeks. So.
From the hospitals that you go to, are they practicing that? Because they're trying to balance, still maintaining the bottom line
Right.
with some good public health skills.
Right.
But are you seeing that those cases have been canceled?
Well, I'm not a surgeon, so I don't know. I'm assuming they're kind of minimizing their cases. I do know that all of the area hospitals have questionnaires for everyone entering the building. Our facility has only 2 entrances. You can only go through the ED and one door. And you're checked off and you're asked whether you have a fever. If you say you have a fever and shortness of breath, we direct you to the emergency room. So there are precautions even just entering the building. Any patients who may be suspected of having it, we limit the number of visitors. In fact, visiting hours for all of the patients has actually been reduced. And so those are the types of things that hospitals are doing.
What do you currently use any telemedicine or telehealth in your practice, and can you see a role for it, particularly now during this pandemic?
I don't, but that is another recommendation from CDC, is that you want to minimize contact. So if you can do things by phone, if you can do it by telemedicine. One of the things that we do very often is routine is neurotelemedicine. So when a patient comes in with a stroke, the neurologist may be remote, but they're examining the patient with camera, with the physician at the bedside. There are ways that you can do that in the home. Patients can have their own automated stethoscopes and things that can take the vital signs, and that can be transmitted to the physician in a remote site. So that is encouraged as well if you have that capability.
Okay. What about any treatments on the horizon or any trials that are going on right now, or any vaccines that we keep talking about? Oh, we're gonna have a vaccine next month.
Well, no, not now. Vaccines are in development. There are no licensed medications approved for coronavirus, but there are some agents that we're doing what we call repurposing. And so things that we know, or agents that we know can kill viruses in vitro, or that in vitro, by that I mean we haven't used it in people, but we know in a petri dish or a test tube it can kill the virus. And there are quite a few that we know can kill SARS virus, which is another coronavirus. One of the medications we use is a medication used for patients who have HIV. Chloroquine, that for treating malaria, that's been repurposed because that's been known to be able to kill RNA viruses. So that's something that some of the clinicians are trying. In addition to ribavirin, which is another antiviral, and the one medication that's really being studied, and there's got to be about 5 or 6 trials, is called remdesivir. It's not readily available, but for certain patients, Gilead is the company that makes it. You send your patient information, and they may, on a compassionate basis, send that out, for you to try on a patient who's infected with coronavirus 19.
Are we seeing any increased prevalence in the HIV community?
I haven't looked at those numbers as of yet. So I really couldn't tell you that. It'll be interesting though.
And I was watching a CNN. That's all I've been doing because they took away all my sports. I've been watching CNN, and I saw a very interesting presentation where they're saying that the CT scan may actually be able to, maybe a little bit more specific, even more so than the testing. So if we don't have the testing available, that would be another way to help diagnose the disease. Have you been using that clinically?
Well, a CT, I don't know that it'll give you a definitive diagnosis, but as you know, as a surgeon, you can have an X-ray that looks relatively normal, but when you do the CT, the resolution is better, and you'll see their ground glass, what they call ground glass infiltrates on CT that you may have missed on a, let's say, underpenetrated X-ray. So quite a few of ours have had a CT.
Okay. And of the patients that you've been seeing, you've been taking care of, what percentage of them have gotten better? What percentage of them have gone to the ICU?
Well, there are patients around Georgia in the ICU. I think that it's so new in Georgia. For example, 2 days ago there were 31 cases. It went to 66 cases. Today I log in there 99. So I would think that anyone in any hospital around Georgia who was in the unit 3 days ago is probably still there. So it's going to take time to get to that recovery point where we can say this many people have recovered. But again, the numbers that I may have told you, 162,000 cases worldwide. 6,000 deaths, but 75,000 considered recovered so far. So the lion's share of people do recover. But those numbers come from countries where I don't want to use this term, but the virus rolled out a little bit ahead of the United States. So some countries are plateauing and almost, dropping off, whereas the United States is really in the thick of things with respect to infection.
What keeps you up at night about this disease? What are you concerned about?
Well, personally, I am certainly concerned about myself. I'm more concerned about my father. I have an 89-year-old father who lives with me. So I'm a little less concerned about me, but I'm concerned about him. So I avoid him. I haven't seen him in a few days. Has someone else cook for him. That's my concern.
And just for all of our healthcare workers out there again, what's the best way they can protect themselves? Do they need to be wearing masks around all day and gloves all day?
Well, on the job, typically our ER is pretty good at screening and pretty good at catching folks who may be at risk. If they have any questions at all, they'll call an infectious disease specialist or call a pulmonologist. So many of ours will come up already on what we call droplet precautions. And when they hit the room, that tells the nurse, wear a mask, wear a gown. We do indicate in the system whether it's a PUI or person under investigation, and that tells the nurse, everyone's educated to know, well, wear eye shields, kind of wear double gloves. And so we have certain clues within the system without giving away patient information. That instructs the healthcare worker, what they need to do to protect themselves. And they minimize trips to the room. They're not in and out. They don't leave the door open and that kind of thing.
Any other words of wisdom or comment that you want to leave with our viewers, including dismissing some of those rumors that we hear about?
Well, that everyone can get it. And my suggestion is to just use those things that we know work. Not touch your face as little as possible. Sneeze into your crook of your elbow or into tissue and discard it. Clean all of the surfaces that are non-porous surfaces in common use, frequently used areas in the home. Try to avoid large social gatherings, over this course of time. And if you do find that you're ill, call your physician. Be very conscious of your symptoms, and if you have any shortness of breath at all, my suggestion is to come to the ED. Try to call ahead, but if you can't, just come to the ED if you have any kind of respiratory distress.
And if any of our viewers want to get in contact with you, how can they get in contact with you?
They can get in contact with me through my office, 404-863-9781.
Do you have a website?
I do. It's atlidc.com, Atlanta Infectious Disease Consultants.
We want to thank you so much for joining us with this conversation. And this is not the end of it. We're going to have ongoing conversations about coronavirus as well as other areas. And again, this is sponsored by the Atlanta Medical Association. Dr. Drayton is a longtime member of the Atlanta Medical Association. And we want to be able to serve our community. We want you to see doctors that look like you. And so please feel free to reach out to us, www.atlantamedicalassociation.org. And thank you for tuning in.